Can you hear me, Dr. Governor?
I can hear you, Dr. Ndongeni.
Thank you.
We
Good
can see your
evening.
slides well.
All right. Once again, good evening to everyone. Thank you for that kind introduction, dear Val. And thank you once again for inviting me to share the little knowledge that I know about the common fungal infections of the skin. We will mainly focus on the superficial fungal infections this evening. We'll touch on the pathogenesis, and then with the use of clinical images, we'll talk about the clinical presentation of the different types, and then the appropriate investigations and management of the different phenotypes. Now, just to introduce fungal infections, we know that a fungal is a eukaryote, and these are multinucleate or multicellular organisms, and they generally have a thick wall around their plasma membrane, and they're found everywhere in the environment. And in terms of size, they're generally larger than a bacterium. They are broadly classified into molds as well as yeasts. Molds are filamentous, and they grow as multinucleate branching hyphae, and they form a mycelium. Now, a mycelium is like a colony of fungi, and asexual reproduction results in the formation of sporangia, which liberates the spores. And then, of course, yeasts grow as ovoid or spherical cells, and they multiply by budding or division. An example of that is Candida. There's different pathogenic mechanisms. The first one, and being the commonest one, is direct infection, and rarely certain fungi mount their virulence by toxigenicity as well as allergenicity, and I'll mention the relevant ones. So fungi are generally able to cause direct infection because of their ability to grow at body temperature. Now, Candida has organoadhesins that tend to adhere to the stratum corneum, and certain fungi, such as Cryptococcus, have got an antiphagocytic capsule which protects them from an immune response. For example, histoplasma generally resides inside the neutrophil, which then makes it resistant to intracellular killing. And we've got there's different virulence with different strains of fungi. Rarely we get the toxigenicity and the allergenicity. And an example of allergenicity is aspergillosis, which mounts a type 1 hypersensitivity reaction, whilst certain toxic fungi produce aflatoxins, and that's how they spread and cause infection. Now, of course, tonight we will focus on the superficial fungal infections, which is the dermatophyte infections, as well as yeast infections. But I think it's important to know that we also do have deep fungal infections, which are categorized into systemic mycosis. An example of this is histoplasmosis, cryptococcosis. We know this. And then we've got subcutaneous mycosis. An example of that would be sporotrichosis, right? And these we do see, especially in the context of immunosuppression. Now, back to the dermatophyte infections, we've got mainly three genera. We've got the trichophyton, epidermophyton, and microsporum. And trichophyton rubrum is the commonest type that causes a superficial fungal infection. And general dermatophytes infect the skin, hair, and nails mainly. And in terms of transmission, you can get a transmission from one person to another. You can get it from the animals as well as the soil, because they are generally everywhere in the environment. Now, superficial fungal infections heal slowly due to the dermatophyte-host interaction, and certain types of dermatophytes have got keratolytic enzymes which tend to break down the condified layer of the skin, and that's where they generally reside. And cell-mediated immunity is crucial in clearing the dermatophyte infection, which then goes to say, once a patient has got an impaired cell-mediated immunity, then they'll tend to have difficulty clearing that infection. So when it comes to superficial fungal infections, we've got the dermatophytes, we've got Candida, and we've got pityriasis versicolor. And I'll briefly go through all of these. But before we go to the different clinical presentations, dermatophytes are generally named according to the body site that's usually infected. So if you've got a dermatophyte on the face, we call it a tinea fasciale or tinea fasciae. And then the body is tinea corporis, the groin, tinea cruris, the hands, tinea manum, feet, tinea pedis, and then the scalp, tinea capitis. When it comes to dermatophyte infection of the nail, if it's caused by a dermatophyte, we call it a tinea anguam. But we know that non-dermatophytes, such as candida, they can cause nail infections as well. And so we use the umbrella term onychomycosis for the non-dermatophytes. Now we'll start off with tinea capitis, which is the dermatophyte infection of the hair on the scalp. So generally, patients with tinea capitis will present with scaly patches of alopecia. They may present with broken off hair shafts, and we will see these as black dots on clinical examination. And then some patients may present with what we call inflammatory tinea, and this will present as painful bulb nodules that drain pus. It does not necessarily mean that there's a secondary bacterial infection, but just inflammatory tinea. And generally in children, one of the other clues is patients will present with cervical as well as occipital lymph nodes. It's important to note that there is a condition called alopecia areata, which is a non-scarring alopecia, again, which is quite common in children, which present with these very, very clean patches, annular clean patches of alopecia without any symptoms. There's no scaling, there's no lymph nodes, there's no bulby nodules. So when you see non-inflammatory tinea capitis, you must also consider alopecia areata in your differential diagnosis. And in terms of treatment, for tinea capitis, we always use systemic antifungals. So for children, we use terbinafine, which is the preferred antifungal, 5 milligrams per kg per day for about 4 weeks. Tinea capitis in adults is rare, but when it does occur, we generally do 250 milligrams daily for about a month. And then if you do not have terbinafine, we can use fluconazole at 6 milligrams per kg per day for about a month as well. Going over to tinea fasciale, which is a dermatophyte infection of the face. Generally, patients will present with these annular patches, again involving the face. The clue to the diagnosis is that patient will have an annular lesion with an active border and a clear center. In this particular image, the center is not exactly clear, it's hyperpigmented, but you can see the border, the erythematous border right there. It goes all the way to there. And then again, the image on the right, you can clearly see the border of this annular lesion. Now, things get a little bit tricky when patients, because patients will kind of start and try and use some form of an over-the-counter topical agent. And the most easily attainable topical is usually a topical steroid. So patients sometimes may come in presenting with tinea incognito, which is now patient will present with this, this disfigurement, which they don't present with that classic annular lesion. They present with these small little papular lesions. You can still see that there's a border, there's areas of hyperpigmentation, but there's loss of that annular appearance. And there's other clues that this patient has been using steroids, such as thinning of the skin, the hyperpigmentation, that shiny appearance. Those are signs of steroid use or steroid abuse. Now, going over to tinea corporis. Now, this is a dermatophyte infection involving the trunk, legs, arm, and neck. And again, like I said, the classic lesion is an annular, scaly patch or plaque with a clear center and an active edge. This is a classic lesion. The center is clear and we have an active edge. This is a patient, darker skin, of course, so it's not very obvious to see the clearance of the active, the center as well as the normal skin. But again, you can see that there is an annular lesion and an active border. Again, there's an active border that goes there, and you've got about 2 circles there that has coalesced to form one lesion. So sometimes in darker skin races, it is difficult to pick up the clearance. But for lighter skin races, it's much, much easier. So we can see these polycyclic circular lesions in this particular image on the right. And then on the left, this I would describe as a nummular lesion. But you can see there's slight clearance there in the center. Then, of course, again, a very, very active border. In immunocompromised patients, the configuration or the classic appearance tends to be distorted. We've got this large, bizarre lesion. They're definitely not annular. There's hyperpigmentation and scaling at the center. But again, the clue is that there's a well-demarcated border. So the borders is where you will find your clue to making that diagnosis of a tinea corporis. Again, more images of tinea corporis. Some of the lesions can coalesce to cause erythroderma. Erythroderma is described as any kind of skin lesions presenting with erythema and scaling involving more than 90% body surface area. So with extensive tinea, patients can present with erythroderma. And then we go on to tinea cruris, which is the dermatophyte infection of the groin. There is the scaling, mainly the scales at the bottom in this particular patient. And then going on to tinea pedis, which is a dermatophyte infection of the foot. We've got 2 main types. We've got the common type, which is called the moccasin type. Patients present with these scaly lesions, mainly involving the soles and the lateral aspect of the feet. And then we've got the bullous tinea again, same distribution, but bullous, small little bullous lesions, mainly involving the sides of the feet, right? And I want to draw your attention to a concept called dermatophyte complex. So sometimes even the most experienced dermatologist might be caught out on this one. So a dermatophyte complex is where you will have tinea pedis, mainly involving the intertriginous regions, with a superimposed Pseudomonas aeruginosa, a Pseudomonas infection, and we call that a dermatophyte complex. This one clue of making this diagnosis is that you will see an obvious intertrigo, and you will use antifungal. You start off with the topical antifungals, you don't get clearance, you get partial clearance, you use your systemic antifungal, but the patient just does not clear, and you get this maceration on the affected areas. Sometimes it can be even more extensive than this. It can be very weepy. You must always think of a superimposed Pseudomonas infection, and you do pass swab, and then you give the appropriate antibiotics over and above the antifungals. So that's a concept called a dermatophyte complex. Again, a differential diagnosis to tinea pedis is, of course, psoriasis, but we know that with psoriasis, you usually get these silvery white scales in a background of a erythematous plaque lesion. So sometimes you can mistake, especially palmoplantar psoriasis, we can mistake it for tinea pedis. Now, onychomycosis, like I said, is an umbrella term for the fungal infection of the nail. If it's caused by a dermatophyte, it's usually tinea anguam, and the most common organism would be Trichophyton rubrum. Yeast candida can also cause onychomycosis, and other non-dermatophytes include aspergillus. So we generally would do nail clippings. Of course, we'll treat the onychomycosis, but usually do nail clippings and send those for culture, so that we can isolate whether it's a dermatophyte or it's a non-dermatophyte. Now, the clues to making a diagnosis of an onychomycosis is that patients will present with these subangual hyperkeratotic scales. In this image, I think we've got more in that particular nail. Sometimes they can present with thickening of the nail plate, as well as discoloration. Some patients may just present with discoloration, no scaling, no subangual hyperkeratosis. And patients generally have these soft brittle nails. So we'll go over some of the images of the different patterns. Sometimes we can get a superficial white onychomycosis. Then we've got a distal white onychomycosis with subangual hyperkeratosis. The proximal white onychomycosis we tend to see in immunocompromised patients. Again, another differential for onychomycosis is always nail psoriasis. But with nail psoriasis, we usually have the oil drop, so you get this yellowish appearance of the nail. And then some of the other clues for nail psoriasis is the pitting and onycholysis, which is separation of the nail bed from the nail plate. So how do we make a diagnosis of a dermatophyte? Generally, a clinical, it's usually, sometimes it can be a little bit challenging. And in those cases, we usually do a K-way scrape. So we take a glass slide, scrape off the scale, put 1 drop of 20% potassium hydroxide, put a cover slide, heat that for about 30 seconds, and put it under the microscope. And we generally see this branching hyphae. So you get these lines that are moving in different directions. So those are called branching hyphae. And in terms of management, of a dermatophyte, we can use, we start off with, especially if it's localized, we do topical antifungal twice a day for about 14 days. So we can use miconazole, which it comes in as Covarex. We can use conazole, clotrimazole, terbinafine cream. And if it's extensive, then we usually switch over antifungals. For tinea anguam, generally we use systemic antifungals. But I think, yeah. And then examples of systemic antifungals, we've got terbinafine, itraconazole, as well as fluconazole. For dermatophytes, we generally do not, ketoconazole is not approved for dermatophyte infection, but it does have its own role. Now, going on to the non-dermatophyte, so we've got 2, the pityriasis versicolor and candida. Pityriasis versicolor is caused by Malassezia pecia.
Dr. Ndongeni, you've gone a bit distant. Maybe if you can come closer to your mic.
Okay.
That's better. Thank you.
All right. So pityriasis versicolor is caused by Malassezia fever. It used to be called Pityrosporum ovale. It's quite common in young adults. High temperatures, oily skin, hyperhidrosis, use of corticosteroids tend to be predisposing factors. And patients generally present with these asymptomatic, hypopigmented macules and patches, mainly involving the upper trunk. You can get extension to the neck, even to the face. Sometimes patients may present with hyperpigmented, scaly, asymptomatic patches in the same distribution. And in terms of treatment, again, we can use a miconazole cream or spray, clotrimazole, ketoconazole, and terbinafine. Those are the topical options. But with pityriasis versicolor, because of its tendency to recur, we usually combine topical and systemic antifungals. So that's where the ketoconazole comes in. Ketoconazole 400 milligrams stat and 400 milligrams after 7 days, and then you can maintain with the ketoconazole shampoo and the miconazole cream. That usually works very, very well. Other options is, I prefer itraconazole. It tends to be superior as far as systemic antifungals are concerned. Fluconazole doesn't have very good results in clearing a pityriasis versicolor. But if you do not have ketoconazole, itraconazole, of course, you can still use your fluconazole. Now, going on to Candida. Everybody knows Candida is caused by Candida albicans. There are other microorganisms of Candida subspecies. It usually tends to occur in moist areas. Predisposing factors include moisture, occupation, and certain drugs. And there's different phenotypes. You can get oral candidiasis, we all know that. Candida intertrigo, balanitis, valvulitis, Candida diaper dermatitis, and paronychia. And I'll just show you some of the images. This is oral candidiasis, whitish adherent plaque, mainly involving the tongue. Sometimes you can get extension to the buccal mucosa. There is something called oral hairy leukoplakia, which again presents with whitish adherent scales, but that's usually on the lateral aspect of the tongue. So remember, oral hairy leukoplakia. And then we've got intertrigo. So intertrigo tends to occur on the folds. So the inframammary region, the neck, and the folds in children. What gives us a clue that we're dealing with Candida and not just eczema or on inverse psoriasis is that with intertrigo, you'll get these beefy erythematous patches with satellite lesions. So on the edges, you can see these small little papules and easily ruptured pustules on the edges. That's a clue to Candida intertrigo. Again, you can get these whitish macerations, mainly involving the finger webs as well as the toe webs. That's usually caused by Candida, and the appropriate treatment is usually required. And then an image of Candida diaper dermatitis with extension to even the popliteal fossa. If you ask me where are the satellites, the satellite in this, they're not very obvious, but the satellites there, you can see them in that particular angle. But in this particular clinical image, the satellite lesions are not very, very, very obvious. And then paronychia. Now, paronychia can be acute or chronic. The acute paronychia is usually a bacterial or a viral cause. And then the chronic paronychia is where patient may present with a chronic hand eczema, and over time they get these superimposed candidal infections. And this patient will usually present with this chronic swelling of the proximal nail fold. It's usually non-painful. In this particular image, you can see that brownish discoloration with longitudinal ridging. So I think there might be involvement of the nail in this particular case. And then in terms of treatment for Candida, topical options include nystatin cream, nystacid ointment, and then systemic options. Fluconazole works very well for Candida, as well as itraconazole. So just to finish up, when do we use systemic antifungal? So if you've got an extensive tinea corporis, we go straight to systemic. If you've got the hair and scalp involvement, systemic antifungals. If a patient presents with onychomycosis or tinea anguam, again, systemic antifungals. And most cases of tinea vesicola, we use systemic antifungals because of that recurrence. And if you use topical antifungals and you don't get clearance, then you switch over to systemic antifungals. That brings me to the end of the presentation. Again, I'd like to thank Glenmark for inviting me, and thank you for making the time.